So there's a lot of different genetic diseases that we're not going to be covering in this class. Tons of genetic diseases. If you wanted to take like an advanced genetics class, you'd probably learn quite a few of those other diseases that we're not covering today. One of the diseases that we're not covering is this one over here. It's Marfan's disease. And Marfan's has to do with the mutation of the FBN1 gene. And basically, it's a connective tissue disorder. Patients with Marfan's will have really long fingers. They'll be very tall stature, very, very slim. Some very famous people in history have had Marfan's. These folks, not as famous, but they are famous in the medical community because it ran in this family. And as you can see, their hands are just like super long fingers. Anyone know who this is? No, it's not Prince. Are you kidding me? That's hilarious. That's very funny. Anyone listen to punk rock in here? No, it's not Ozzy Osbourne. It's Joey Ramone from the Ramones. So Joey Ramone, the singer of the Ramones, had Marfan's syndrome. Anybody know who this is? Okay, good. At least you knew who Abraham Lincoln was. I doubt any of you are going to know who this is, but if you do, I'll be extremely impressed. Anyone? Huh? It's a classical music composer, pianist, specifically. Huh? Beethoven? No. There are no known existing photographs of Beethoven. So this is Sergei Rachmaninoff, one of the greatest classical piano players. Did you say it? You were going to say that? No, okay. Sergei Rachmaninoff is an amazing piano player. I can hit I can hit 10 notes on a piano, like as an octave, beyond an octave. The octave is 8 notes. I can hit 10 notes, at least with my left hand. Sergei Rachmaninoff could hit like 16 notes with his hands, like just massive stretch. And he was an incredible pianist, an incredible composer. Really, really amazing. Born in Russia, moved here to the United States. Just awesome guy. Just really, really good stuff. But anyways, all these guys had Marfan's syndrome. So super interesting condition. It can predispose people to some other issues, right? In and of itself, it's not necessarily a bad disease. People can live a pretty long life with Marfan's, right? I mean, Abe Lincoln didn't die from Marfan's, obviously. But it can affect your blood vessels, your heart. It can affect your skin. It can affect lots of different parts of your body, right? The heart would be like the biggest problem, right? If you have any sort of issues with your heart. And we're going to talk about some of these genetic diseases do affect the cardiovascular system. So of the diseases that we're going to be covering, we're going to be talking about achondroplasia, right? So that's like one of the types of dwarfism. Is it proportional or disproportional dwarfism? Disproportional dwarfism. Good. We're going to talk about autosomal dominant polycystic kidney disease versus autosomal recessive polycystic kidney disease. We're going to discuss cystic fibrosis, sickle cell anemia, Duchenne's muscular dystrophy, Down syndrome, Klinefelter's, Turner's, and congenital heart defect, i.e. just one, basically, tetralogy of Fallot. That's the only one that you're going to be responsible for this next exam. I'm not going to go over the basics of genetics. This is just a review of the stuff that you should have already learned in the past, just basic biology, talking about alleles, talking about the regular chromosomes versus the sex chromosomes, homozygous versus heterozygous. This is all basic review for you guys. Also go into like deletions versus duplications and inversions, insertions and translocations. Those are all different types of genetic conditions. If you want to test yourself on these, feel free to do so. You can go into this quizzes on your own time, but I'm not going to do that with you guys today. So, genetic diseases can fall under different types of categories. They could be single gene mutations. There's a lot of genes. There's a lot of diseases that are literally just one single gene got mutated, and now you have a disease. Right? One example is autosomal dominant polycystic kidney disease. Achondroplasia is another one of those. Cystic fibrosis, we talked about the CFTR gene already, twice in respiratory as well as in pancreas, right, when we were talking about GI disorders. There's also X-linked diseases, so X-linked recessive. Does that affect men or women? Yeah, it's going to affect men because guys only have one X chromosome, unless you have Klinefelter's and you have two X chromosomes, which we'll talk about today. So Duchenne's muscular dystrophy only affects guys. Chromosomal diseases, so there could be abnormality of the chromosome, like numbers or the structure. Numbers, trisomy 21. Klinefelters, you have 2 X chromosomes plus a Y chromosome. So these diseases can be affected by too many or too few chromosomes, or it could be having to do with just swapping out different portions of the chromosome, like translocations, for example, like the Philadelphia chromosome, for example, in CML, right? Which we learned about already this semester. And there's also multifactorial diseases too that involve many genes. Oftentimes, this can be hereditary, right? You can inherit the gene mutation from the parent, or it could be a mutation that occurs during meiosis, i.e. translocation, where you're swapping out one segment of a chromosome for another segment of a different chromosome, swap them over, now you have a genetic disease. They could be autosomal dominant, right? So even if you're heterozygote, you're still going to have the disease because you have that dominant allele, right? Huntington's is a great example of that. Huntington's is autosomal dominant. If dad has Huntington's, 3 out of 4 of those kids are going to have Huntington's disease. Only 1 out of 4 of those will not have Huntington's. It could be autosomal recessive. Sickle cell anemia is a really great example of that, right? If you carry the sickle cell trait, you're heterozygous, what are you protected against? Malaria. Good. Awesome. Cystic fibrosis, also autosomal recessive. It could be sex-linked. So hemophilia, right? We talked about how hemophilia predominantly affects boys. There is hemophilia C, which affects girls, but that's extremely rare. It's usually hemophilia A and hemophilia B. Color blindness usually affects guys. My best friend, he's colorblind. So he can't see red-green differentiation. He always has to ask me what the color is of stuff. I mean, we have a business together. I did all the artwork for our labels and stuff. He was always having to ask me or put trust in me that I knew what the colors looked like because he didn't know what the hell it looked like in terms of colors. So that happens to a lot of guys that color blindness. Actually, by show of hands, anyone in here have color blindness? Any of the guys in here? Nobody? Oh, wow. That's actually pretty surprising because it is a pretty common condition. And then it could be sex-linked dominant. We're not going to talk about Fragile X or vitamin D resistant rickets in this class, or it could be mitochondrial. Mitochondrial diseases are inherited from mom because you get the little tiny circular DNA in the mitochondria from mom, right? You don't get that from dad. Mitochondria has its own DNA, right? That's all part of the endosymbiont theory of mitochondria. It used to be like an individually living prokaryote, and then eventually got integrated into a eukaryotic cell. So let's segue into dwarfism. Dwarfism, you have a height of less than 4'10". You are considered someone with dwarfism. So half of my wife's family falls in this category because they're all from Mexico and they're very, very short. Right? My wife's grandma is really, really short. So if you're less than 4'10", you're considered dwarfism, I guess. There's a lot of different subtypes. Right? There's the proportional versus disproportional dwarfism. The disproportionate dwarfism, you have shorter limbs. Your head is going to be relatively larger compared to the rest of your body. FGF3, that's a fibroblast growth factor receptor 3 mutation, is what causes achondroplasia. So we'll talk about that in more detail. And then we talked already about proportionate dwarfism. That's just a growth hormone deficiency. You just don't have enough growth hormone. Anybody know Hezbollah? You guys watch him on the internet? Yeah, he's awesome. He's so funny. So he's definitely a really famous case of dwarfism. There's a lot of famous cases of dwarfism. And then there's those primordial dwarfisms. These are going to be autosomal recessive diseases. And their body is just really, really, really tiny in general. So here's achondroplasia, right? Very, very famous people have this. Right? Peter Dinklage has this. Wee Man from Jackass has this. Right? These individuals can live totally normal lives, basically. Right? It's not really a disease. So, yeah, there's that. I mean, intellectually, they're going to be the same. They're mostly normal in most respects, except for their height, basically. Fibroblast growth factor receptor 3. Make sure you know that gene mutation. That's very important for this disease as well as for this class. If you diagnose this, you can do genetics testing. You could look at x-rays. The hands are going to have a little trident presentation. So it has a little divergent in the ring finger, so it looks like a trident. It's autosomal dominant, So 3 out of 4 of the kids will have this, right? Even if they're heterozygote, they're still going to be short statured. Versus 1 out of 4, right? 1 out of 4 of the kids will be normal. So, for example, look at this family right here. Everyone has achondroplasia except for these two, right? They're the ones that were the exception to the rule. This is autosomal dominant. This is primordial dwarfism. I'm not going to play this video. It is extremely interesting. I highly recommend watching this on your own time. It's very, very cool. It goes into basically the life story of this individual right here on the top left, same as this individual over here on the bottom right. So that's primordial dwarfism. And again, I'm not going to go into too much detail on that disease. Make sure you know achondroplasia. Now let's switch gears and talk about the kidneys. This is polycystic kidney disease. If you ever want me to show you what a polycystic kidney looks like, I can take you to one in building 1. We have a bucket of organs. We actually have polycystic kidneys that we harvested from one of the cadavers. They've been in this bucket now for like over 10 years. And we keep it there because it's super interesting. It's very rare to see polycystic kidney disease. And if you look at a polycystic kidney, it's huge. It's like the size of a pig kidney. Pig kidneys are really big. Our kidneys are supposed to be at the size of our fist. Right? So if you go to the cadaver lab in building 57, you can take a look at the kidneys and the cadavers. They're about the size of a fist. They're very tiny. Versus a polycystic kidney is huge, the size of a football. And so it's going to happen bilaterally. So imagine having a football-sized kidney in your retroperitoneum. And imagine how uncomfortable that would feel. So there's 2 variants. There's autosomal dominant and there's autosomal recessive. Autosomal dominant polycystic kidney disease presents later in adulthood. I'm talking like around 40 or so years of age. Whereas autosomal recessive polycystic kidney disease presents in childhood, so very, very young. What are the symptoms that you see? Hypertension is going to be one of the major symptoms. Hypertension, you also feel the pain in your flanks, right? So you can maybe get a little bit of that costovertebral angle tenderness, which we're going to talk about when we get into renal in a little bit. You could see blood in the urine, so hematuria, and you see lots of infections. This is also going to affect other tissues in the body. So it can actually predispose individuals to getting aortic aneurysms, cerebral aneurysms. So it's affecting blood vessels as well. It's not just affecting the kidneys by itself. CT, ultrasound, genetic testing, those would be ways that you can actually test for that. Look at the size of those. They're the size of footballs. Absolutely huge. Look, it's like literally causing this patient's flanks to bulge out. That's how big these kidneys are. Just absolutely massive. Let's watch a little video of surgeons having fun with kidneys. Oh my gosh. Just give me 1 second so I can log in. This computer's been like logging me out of everything. I've been trying to get IT to help me out here, but you know how that goes. All right. I hit yes, but it's still not logging me in. Give me 1 second. Sorry, guys. I really want to play this video because it actually is very cool. Sorry, guys. Why is it not working? Oh, man. This is so annoying. I don't know why it's not working. Let me exit out of this thing and try it again. Oh, oh man. There we go. All right. So literally fluid-filled cysts. Just absolutely wild. Does that look like fun? It's almost like preparing a nice, delicious fillet or something. He's like having way too much fun with that. You got to make the best out of a bad situation, right? You got to have fun, even if things aren't going well. Yeah. The hypertension is going to be caused by the inability for renal function. So you're basically you're building up fluids, right? You're building up fluids in your body. So that's going to, in and of itself, cause hypertension. All right, switching gears now. We already talked about cystic fibrosis quite a bit. Just remember CFTR gene. That is the most important aspect of this. And it's autosomal recessive, and it's going to be involving the chloride ion channels. And so, in other words, it's going to affect your lungs. You're going to get really thick mucus secretions. You're going to get lots of infections. It's going to affect your pancreas. It can cause pancreatitis. And then you can test it. You can test individuals by doing like a salt type of test, salt chloride test on the skin. Right? You'll have too much salt and sodium chloride on the skin. Yeah. No, it's not nothing like contagious or anything like that. Yeah. The only thing is these individuals are more prone to getting Pseudomonas aeruginosa infections in the lungs. Yes.
About polycystic kidney disease. So when someone gets a kidney transplant, that would be like the procedure.
Yeah, they would have to get a kidney transplant.
So then when you get a kidney transplant, wouldn't it also be
No, not at all. Not at all. Because this is during it's a genetic disease. So it's a genetic mutation. And so if you got the kidney from a donor, you wouldn't, the genes would be totally different in that tissue. So again, Pseudomonas aeruginosa infections, pneumonia, salty skin, oily stools, barrel chest because of the lungs getting involved, and failure to thrive. Those individuals tend to not do so well. Thank God nowadays the treatments that are available actually are pretty helpful. Individuals can live pretty decent lives nowadays. Whereas maybe 20, 30, 40 years ago, patients would often die in their 30s. So longevity now has increased significantly for these types of patients. But just remember those genes that are involved in cystic fibrosis, CFTR gene, chloride channel, thick mucus production, and then a sweat chloride test to test for that. Sickle cell anemia, switching gears again, that's going to be where your blood forms little sickle-shaped structures. It's going to be hereditary hemoglobin deficit. Sickle cell trait, you're resistant to malaria, but if you are homozygous for the recessive allele, now you have sickle cell disease. Awful disease. I saw this a lot when I was working and studying in Dominica, because Dominica is like 99% Afro-Caribbean. And so a lot of the descendants come from areas that were very endemic with malaria. And so there was a lot of patients that we had that had sickle cell disease. Very painful disease. You get claudications in your joints, so you get really bad joint pains. You can get infarcts because the sickles will literally block blood vessels. And people can actually get strokes from that. And they can get heart attack from that. And it's very painful. So it's a really horrible condition. The only way to treat it and cure it truly is by doing a bone marrow transplant. Otherwise, you have to give transfusions. And these patients get lots and lots and lots of frequent transfusions. Yeah.
Fun fact about sickle cell anemia.
Yeah.
In some countries, people are not allowed to get married. They're supposed to get tested
before.
And if they both carry the gene or the trait, the genes, they're not allowed to get married.
That sucks. Yeah. Which government or which country?
I think some parts of Nigeria.
Only
because a friend of me told me.
Nigeria.
No. Only because a friend told me. I'm not from Nigeria, but I know that some.
Well, basically, it's a matter of choice.
Yeah.
Okay? So it depends on you love this guy, you love this girl, you want to marry.
Yeah.
So you have to know that hey, medical stuff, you're really getting kids
Yeah.
that may not be healthy.
Right.
Towards that, right? So it depends on choice.
So in other words, they get tested. They're recommended that they get tested, and then even if they come out, it's like Ashkenazi Jewish populations.
Yeah.
Like if an Ashkenazi Jewish woman and wants to marry a Jewish man, it's generally recommended that they do lots of genetic testings because of Tay-Sachs disease, because of a lot of different conditions, right? So that's a really interesting thing. And yeah, it's like if you have this type of condition running in your family, it's like good to know, right? Just so you know what you're doing. You know what to expect, just in case you have to prepare. So again, this is recessive disease, so it's going to be like 1 out of every 4 children will actually get the disease. 2 of them, if the parents are heterozygotes, two of the 4 will be the sickle cell trait carriers, which means that they're heterozygous. Feel free to watch this video on your own. This basically talks about how sickle cell anemia was traced back to certain regions in Africa because of mosquitoes. This is like a really, really awesome documentary talking about the doctors who ran these original studies. Very cool stuff. So highly recommend watching that on your own. We're not going to talk about Jerry's kids, but this has to do with muscular dystrophy and how muscular dystrophy there did these fundraisers back in like the 1950s, 1960s to raise money for research and support for patients with muscular dystrophy. So you can read more about this if you like, Muscular Dystrophy Association. What is muscular dystrophy? So there's a region called the costamere, and that's where you have the sarcomere binding to the sarcolemma, or the cell membrane of your muscle cells. The dystrophin protein is a really important protein that is important to allow for this binding to take place. Without the dystrophin protein, you're not going to get like the anchoring of these structures into the cell membrane of the muscle cell. And so muscular dystrophy is going to be seen on the X chromosome, i.e., more men are going to be affected by this disease. So Duchenne's muscular dystrophy in particular is a really sad disease. This is one of the saddest diseases because it affects little kids. And by the time the kid reaches about 5 years old, mom and dad are starting to notice things are a little weird. First of all, the kid, when they walk, they're going to be starting to walk on their tippy toes. You're going to look at their gastrocnemius, or their calf muscle. It's going to be really thick and large. It's not muscle. It's actually being replaced by a bunch of like junk tissues. Right? The muscle itself is actually not functioning properly. So it's basically getting replaced by fatty tissues and things like that. So you get pseudo-hypertrophy. That's what that's called. You get lordosis as well. Right? There's lordosis and kyphosis. Kyphosis is you're hunched over. Lordosis is you have an excessive arch in your back. This happens naturally to like pregnant women, for example. While you're carrying a child, there's going to be a natural arch to the back. Eventually, as the disease progresses, this is affecting muscles. By the time the kid is about 10 to 12 years old, he's in a wheelchair. By the time he's about maybe 17 or 18, he's dying of respiratory failure. So it's a really, really, really sad condition. How do you do a physical exam to see what's going on? You look for the Gower sign, which is a very specific way that these patients try to get up on their feet. So we'll watch a little video of this. So they roll over. They kind of have to crawl their way up. They slowly move their feet closer up, and then they kind of have to bring themselves up with their hands in order for them to get up straight on their 2 feet. So that is a Gower sign. And notice, that kid is very young. That kid was only, like maybe 5 or 6 years old. So horrible, horrible condition. And if you do a biopsy of the muscle, you're going to see the muscle is going to be full of all this like junk, fibrous type of tissue, right? So the muscles are basically getting completely affected. By the time they're in their teens, they're wheelchair bound. And then again, they go into like respiratory failure. So that's what usually kills the patient. What's the difference between these 2 karyotypes? Which one's normal? The one on the left is normal. Good. What's weird about the one on the right? Yeah, there you go. So that's trisomy 21, which is Down syndrome. Trisomy 21, Down syndrome patients, their life expectancy can vary depending on the severity. Some individuals will be pretty normal, whereas other individuals might not live as long. So it really just depends on the severity of the condition. A lot of these individuals aren't even born because they like literally just go into spontaneous miscarriage. 5,000 babies born per year. Maternal age is one of the major risk factors. Once you're over 35 years of age, your risks of giving birth to a Down syndrome baby goes up way high. Not everyone, though. My mom was 41 years old when she had me. And as far as I know, I'm pretty okay, I think. I think. I don't know, I got my own problems. But so it's not everyone that's going to have Down syndrome, right, when you get to that age. Maternal age, though, does increase the risk. That's it. It's not going to be a guaranteed, but it's going to increase the risk. What are some of the things that you're going to see? You're going to see a single palmar crease. You're going to see flat facial features. You're going to see slanting of the eyes. What else? IQ might be affected, but not always. Some patients with Down syndrome do really well. I follow a lot of folks with Down syndrome on Instagram because they're really interesting. And like they live like normal lives. Right? This is one guy who's like really obsessed with like hot dogs and stuff. Like all of his posts are hot dogs, and he plays music too. So I'm like, this guy's awesome. There's another guy who literally thinks he's like an elf. He like dresses up as an elf. He goes out in the forest. He's got like a little sword and stuff. Like, wow, that's really, man. So it's cool. I mean, these folks like live happy, normal lives, right? A lot of them. Again, Alzheimer's symptoms as maternal age goes higher, the more likely you are to develop this. Now, the only thing that's really bad is increased risk for heart defects, so atrioventricular canal defects, as well as leukemia, as well as Alzheimer's dementia. So those are some of the big things that might happen with patients with Down syndrome. People can test for this in the womb. So if you're a pregnant mom, you can do amniocentesis to check to see if your kid has any sort of genetic diseases. There's a handful of diseases that are routinely checked for. You could also check the blood for DNA abnormalities. That's a newer test that came out recently. And then you do karyotyping as well. Yeah.
Do you go back to the 2 slides?
Yeah.
So those percentages at the bottom, is that percentage of birth?
Yeah.
Like, okay.
Yeah. So once you're over 45 years of age, 1 out of 30 are going to have Down syndrome.
5,000 babies born, that doesn't seem like that matches up with those percentages. How many babies are born every year? That seems like 5,000.
I'd like to confirm that too. Why not? Let's confirm it. It says 6,000, according to the CDC. So I need to update my slides. So here's that single palmar crease. You can see widening of the toes as well. And then this is the atrioventricular canal defects. You can get a defect between the atrium as well as through the ventricles. And here's your ventricular septum. You can get a hole basically right through that. Here's another image of what that looks like, atrioventricular canal defect. So that's Down syndrome. Let's switch over to Klinefelter's now. Again, Klinefelter's is where you have an extra chromosome. You have an extra X. So this is considered 47XXY. Your testosterone to estrogen ratios are going to be abnormal. These patients are going to have very little testosterone, and they're going to have kind of like ambiguous genitalia. They're going to have a very tiny testes. They're going to have very tiny penis. They're also going to have gynecomastia. They generally tend to be very tall, so tall stature, gynecomastia, decreased testosterone. Sometimes people don't even know they have Klinefelter's until they get tested for testosterone. My colleague, Dr. Jackson, was talking about a patient of his that was like, they were trying to have a kid, him and his wife, and he did like testosterone level checks and stuff, and they found out that he actually had Klinefelter's. They didn't know, right? So there's going to be varying degrees of severity in Klinefelter's as well. Language and mental abilities might also be impaired in these patients. So they might have like lower IQ, for example. So you do a clinical exam on these patients. You check for chromosomes. You look for hormones. You could do hormone replacement therapy. You could do language therapy to treat these patients. Here's a couple images showing gynecomastia, tall stature, atrophied genitalia. So those are all things that you would see with Klinefelter's disease. Yes?
So what's the condition where an individual has both the and male genitalia.
There's different like congenital adrenal hyperplasia is an example of that, where they have there's a missing hormone. I'm trying to remember which one it is.
So it has
It's
nothing
like
to do with
I'll-
their chromosomes.
11 or I think it's like a 16 and 21 hydroxylase deficiency, if I remember correctly, where they're not getting enough testosterone production. And so they get born and it's like, I don't know what this is, right? They have like features of both, male and female genitalia. So it's kind of hard to tell. You'd have to do like genetic testing to
But I
really
was
see.
going to ask him, like, does it have to do with their chromosomes? Or not?
Mutations happen sometimes. The 21 hydroxylase deficiency, I think, is just random mutation, if I remember correctly. So, good question. There's other diseases that can cause hermaphroditism. There's, like, for example, testosterone. There's androgen insensitivity disorder, where a person, when we're all like developing in the womb, we're basically starting off as female. And then if you have the Y chromosome, you're going to have the SRY gene, which is going to help you develop male characteristics, testosterone, etc. But individuals born without androgen receptors, so androgen sensitivity, they're going to be looking like a woman. For all intents and purposes, they are a woman until they can't get pregnant, and then they go get like a pelvic exam, and they find out they have a blunted vagina, no uterus, and no functioning ovaries. So they look like a lady, but they aren't. They're actually a guy, but they just didn't have the receptor sites for testosterone during development. So that's a really interesting condition that happens to some people. So there's different diseases that can affect like male and female characteristics, long story short. Turner syndrome is another interesting disease. This is 45X or 45XO. This means that you only have one X chromosome. And this happens to quite a few individuals. 1 out of 2,500 people are born with this condition. Short stature, they're going to have irregular menstruation. They're going to be sometimes infertile, low estrogen, and they might have increased risk of ovarian cancer. Some of the distinctive features that you would see on them, besides being short, is a webbed neck. You're going to see kind of like webbing on the sides of their neck. You can also see heart defects, so coarctation of the aorta. I'll show you that in a second. You can also check for hormone levels and then do hormone replacement as one of the treatments. This is coarctation of the aorta. Here's the aorta, and all of a sudden you have narrowing right there. Now, how is that going to affect the blood pressure? How is that going to affect the blood pressure in the arms? Is it going to make the blood pressure in the arms go up or down? Up. Why up? Good. Yeah, the brachiocephalic artery. So you got brachiocephalic artery going to the right. So you got brachial, which turns into to the arm, right? Goes to the arm. And then on the left, you have the subclavian artery, right? Going to the left arm. And so if you constrict the aorta here, you still get more blood pumping through the upper extremity, right? Head and neck. So you're going to get increased blood pressure in the arms. And then your lower extremity is going to have decreased blood pressure. Does that make sense? Cool. So that's coarctation of the aorta. Here's a nice CT scan with contrast so you can see where the coarctation is. Super cool. Here's a gal with Turner syndrome. That's when she was young. That's when she's older. As you can see with her neck, she's got that webbing of the neck. Right? Coarctation of the aorta is going to be by far one of the more severe aspects of this disease, as well as infertility. Right? Here's a Turner syndrome baby. You can see that webbing of the neck. So Klinefelter versus Turner's, make sure you're comfortable with what it looks like in terms of karyotyping. 45XO for Turner's, 47XXY for Klinefelter's, and we're going to close out with congenital heart defects. The only one that I'm going to hold you responsible for is this guy right here, tetralogy of Fallot. Sorry about that. Tetralogy of Fallot is the only one of these diseases I'm going to cover for you guys. So tetralogy of Fallot, tetralogy meaning 4 symptoms to this. There's 4 things that you're looking for. Ventricular septal defect, so you're getting blood going between the ventricles, right and left. Aortic transposition, so the aorta is like basically an overriding aorta. They also call this overriding aorta. And pulmonary stenosis, so blood is having a hard time getting into the pulmonary trunk, as well as right ventricular hypertrophy. Those are the 4 signs and symptoms of this disease. I would put a big star on these symptoms because that is going to show up on your final exam. When this individual is born, they're not going to be getting good blood circulation, so they're going to be blue. So it's blue baby syndrome. They're going to be cyanotic at birth. So here's what it looks like. You can see the overriding aorta. You can see the narrowing of the pulmonary trunk. You can see a ventricular septal defect, and then the right ventricle is going to be nice and hypertrophied. And that's it for genetics. Let's log in, do one question, and then we're going to switch over to renal. I'm going to blast through renal with you guys because I do want to get it done today. So I want to do reproductive pathologies on Friday. So I know it's a lot of information to cover within 1 week, so I apologize for that. But you guys will do good. By the way, your class average for the last exam was really good. I think it was like 83% or 84%. So good job. You guys did wonderful in the last exam. Did you guys think the last exam was harder than the second exam? No? Some people say yes. No? Second was way harder. So it's like it depends on what if you like cardio and neuro. So cardio can be pretty tough for some people. I had some students say that the last exam was much harder. So I don't know. All right, let's go ahead and begin. I'm only going to do one question here, and then we're going to switch gears. All right, so that was achondroplasia, right? This is autosomal dominant disease. Okay, so in other words, if mom and dad have achondroplasia, 3 out of the 4 kids are going to have it, right? If mom and dad are heterozygotes. And it's going to be the fibroblast growth factor receptor number 3. All right, so I'm going to end that now and make sure you do the rest of those questions on your own time.